We continue with Jena and Worsham's Random Acts of Medicine, the sixth and final part of the interpretation. The theme of this section is how to become a good doctor. There are two ways to judge if a doctor is good. One is to look at the results, with the simplest statistic being the lower the mortality rate of the patients they treat, the better. However, simply looking at results doesn't help doctors improve because you don't know why others are doing better. Another way is to look at methods, to see which doctors' treatment methods are strong. This aligns with the consistent principle of decision science. Don't focus on outcomes. Focus on processes. But medicine is a complex field, so how do we know which method is good and to what extent? Jena and Worsham list some studies. The brilliance of these studies lies in showing who the good doctors are based on results and, by comparing doctors, revealing which methods are most important. By examining these studies comprehensively, you gain a deeper understanding of the modern medical system. 3 benefits with 1 question. Imagine one day you go to the hospital. The nurse conducts basic checks, asks about your condition, and leads you to a consultation room to wait for the doctor. You wait anxiously for 10 minutes until the door finally opens. Do you prefer the doctor entering to be older or younger, male or female, of the same race, or a foreigner? Is it necessary for them to be a graduate of a prestigious institution? Before exploring the level of doctors, we must understand that doctors can be divided into 2 basic categories. Internal medicine, hospitalists or internists, and surgery, surgeons. In simple terms, internal medicine doctors diagnose and prescribe medications, providing comprehensive care to patients. Surgeons, on the other hand, handle surgeries and surgery-related care. The knowledge structure, training methods, and growth paths of these 2 types of doctors are very different. We'll discuss the specifics later, but first, an interesting anecdote. A senior doctor once told me that the personalities of internal medicine and surgery doctors are different. Generally, surgeons are more straightforward, more communicative, and act more decisively. Internal medicine doctors, you might sometimes be unsure of what they're thinking. Of course, you can't freely choose between internal medicine and surgery based on your condition. It depends on the illness. Often, you can't choose a specific doctor. It depends on which doctors are on duty at the hospital, randomly assigned. And this randomness provides an opportunity for researchers to compare doctor competence. Let's first look at the relationship between a doctor's age and competence. Traditionally in China, there's a reverence for experienced experts, especially elderly traditional Chinese medicine practitioners, believing that the older a doctor, the more experienced. However, have you considered that, generally, as people age, their ability and willingness to learn new things decline? If medicine is continually advancing, can older doctors keep up? Whether experience or new knowledge is more crucial, let's take a look at the hard evidence from statistical research. Starting with internal medicine, a study examined 730,000 patients aged 65 and above managed by 19,000 doctors between 2011 and 2013. Considering all the natural experiments required, excluding confounding factors like critically ill patients being more likely assigned to older doctors, the conclusion was: the mortality rate of patients within 30 days of admission in the hands of doctors under 40 was 10.8%, 40 to 49 years old was 11.1%, 50 to 59 years old was 11.3%, and for doctors over 60, it was 12.1%. The differences aren't significant, but the trend is clear. The older the doctor, the higher the mortality rate of their patients. Certainly, older doctors have more experience, but younger doctors achieve better therapeutic outcomes. Why? Because younger doctors can grasp the latest drugs, therapies, and technologies. They've just graduated from residency training, recently exposed to the latest medical knowledge. For internal medicine, up-to-date knowledge is more useful than clinical experience. However, for surgery, experience becomes more critical. An analysis of 46,000 surgeons and 900,000 surgical cases showed that for surgeons, the older they are, the higher their competence. The postoperative mortality rate for surgeons under 40 is 6.6%, 40 to 49 years old is 6.5%, 50 to 59 years old is 6.4%, and for surgeons over 60, it's 6.3%. Why? Because surgery is a skill that requires practice, more about honing skills than theoretical knowledge. In summary, internal medicine doctors need to focus on acquiring new knowledge, while surgeons need to practice their skills more. Younger individuals are adept at learning new things, while older individuals accumulate more practice. An interesting variable is the total number of patients seen annually. Both for internal medicine and surgery, the more patients a doctor sees, the higher their competence. However, it's challenging to determine whether high competence leads to more patients or more patients lead to higher competence. Yet, the statistical results do suggest that as long as the number of patients seen is sufficient, older internal medicine doctors have the same competence as younger doctors. In contrast, for surgery, a higher number of patients doesn't necessarily improve the competence of older doctors. So here, through statistical research, we've discovered the two essential skills determining a doctor's competence. Knowledge and skills. The newer, the better for knowledge. The more practiced, the better for skills. Another question is whether male doctors or female doctors are more competent. Firstly, it's crucial to mention that despite years of gender equality movements, female doctors in the medical field still face significant disparities. In 2019 data from the U.S., women comprised 51% of medical school applicants but only 48% of medical school graduates, 46% of residency training graduates, 41% of medical school faculty, 25% of fully promoted medical school professors, and 18% of medical school deans. In essence, female doctors initially start on an equal footing with male doctors but gradually fall behind. Another statistic found that the lifetime income of female doctors in the U.S. is, on average, $2 million less than that of male doctors. Perhaps the general impression is that female doctors are not as good as male doctors, and this sentiment might persist even within hospitals. For instance, if a patient needs surgery, you might prefer a male doctor. If a female doctor's surgery results in a patient's death, other doctors may be less willing to entrust patients to her again. But are female doctors really less competent than male doctors? We need statistical conclusions while controlling for interfering factors. The conclusion is, for surgery, there is no significant difference in postoperative mortality rates between male and female doctors. For internal medicine, the competence of female doctors is higher than that of male doctors. The patient mortality rate for female internal medicine doctors is 11.1%, with a readmission rate of 15%, whereas for male internal medicine doctors, the patient mortality rate is 11.5%, with a readmission rate of 15.6%. I suspect the reason why female doctors lag in income and promotions might not be solely due to gender discrimination but more because they have to spend more time caring for their families. Perhaps women are not as willing to devote all their energy to work, and this actually highlights the value of female doctors. If given a choice, you'd prefer your doctor to be female. So, where exactly are female internal medicine doctors superior to male internal medicine doctors? What do they do that male doctors don't? In terms of knowledge and skills, male and female doctors are quite similar. Researchers made a lot of efforts but found only one difference. Female doctors are more willing to communicate with patients. On average, female doctors spend more time with each patient, pay more attention to the patient's emotions, and are more willing to provide counseling. This makes patients more receptive to the advice of female doctors. The following facts will prove how crucial this is. Communication is the third skill of doctors. In the United States, conducting studies related to people has an advantage due to the diversity of American society. It includes people from all social classes, races, and immigrants from around the world, leading to interesting occurrences. Of course, race is a sensitive topic, so Jena and Worsham don't discuss which race of doctors is more competent in this book. However, they mention an interesting phenomenon. Doctors of the same race or who speak the same language as the patient can better help that patient. For example, a study on preventive medical services found that Black individuals are more willing to accept advice from Black doctors. Compared to seeing non-Black doctors, when Black patients see Black doctors, the likelihood of receiving weight management-related services increases by 27%, diabetes screening increases by 49%, and cholesterol screening increases by 71%. Another study found that an adult whose native language is Spanish has better results in diabetes treatment when facing a doctor who speaks Spanish. Why? Trust. If doctors share similarities with patients, they are more familiar with the patient's environment, understand the patient's story better, and thus, can comprehend the patient more easily. As a result, patients trust them more. If they suggest a test, prescribe a medication, or advise a lifestyle change, patients are more likely to accept. You understand me, so I trust you. Black people make up 14% of the U.S. population, but Black doctors only constitute 5% of the U.S. doctor workforce. So, Jena and Worsham speculate. Is it possible that because Black individuals haven't encountered many Black doctors in hospitals, communication is less smooth, leading to less effective treatment for Black patients? Is this related to the fact that the life expectancy of Black Americans is 6 years less than that of white Americans? The last question is how much impact a doctor's origin has on their medical skills. Can you guess if there's a significant difference in the actual workability between doctors who graduated from prestigious universities and those from ordinary ones? Is there a difference in competence between doctors trained in the U.S. and those educated abroad who later immigrated to the U.S.? This is probably the first study I've heard of comparing the practical workabilities of graduates from prestigious and ordinary universities. The answer is: there's no difference. Whether you graduate from Harvard or Harbin Buddhist College, as long as you graduate from medical school, complete residency training, and pass the licensing exam, your medical skills are unrelated to your alma mater. Statistics show no correlation between university rankings and patient mortality rates. However, doctors who received medical education abroad and then worked in the U.S. have slightly higher competence than doctors trained domestically. The patient mortality rate for international medical graduates is 11.2%, while for U.S. graduates, it's 11.6%. This is mainly because the U.S. is selective in attracting global talent. Only outstanding doctors can obtain work visas. So, if you're looking for an internal medicine doctor, you'd prefer a relatively young female. If it's for surgery, you'd prefer an older doctor. Ideally, your doctor would share a similar cultural background and speak the same language. As for whether they graduated from a prestigious institution or where they were born, that's not important. But the real essence of this section is not in the closely aligned statistical results. Instead, these results illustrate the three most crucial skills for doctors: knowledge, practice, and communication. Of course, these are only U.S. data, and there might be different data in other countries. But the interesting fact is the small differences in competence among different types of doctors. It suggests that as long as the hospital meets standards, there isn't a significant difference in where, or with whom you seek medical treatment. If a doctor in a provincial capital says this is how the disease should be treated, you'll find the best doctors in Beijing saying the same, and upon further investigation, doctors in the U.S. follow the same protocol. With this, we conclude the sharing of Random Acts of Medicine. The remarkable feature of this book is its examination of very subtle and delicate differences. I would say the bigger conclusion is that doctors are actually quite similar. Doctors worldwide form a community, which is fascinating. It's not a particular doctor treating you. It's the current scientific understanding in the medical field treating you.
If you feel there is value in this, please like, subscribe to this channel, and leave your thoughts or suggestions in the comments section. Let's grow together and read more good books.